Now I'm actually going to hand it over to Sylvia Trujillo, and she is the Senior Director of Policy for OCHIN, and she is the leader of our policy panel today. And over to you, Sylvia. I'm actually going to stop sharing so she can start sharing her screen.
Hold on just a moment. I am adjusting. Make sure you all can see. And can I get confirmation that you can see the policy panel screen?
No.
Yeah,
don't see it.
not seeing it yet.
Okay, let me escape one last time. Share my screen. All right, folks, just a slight adjustment.
And let me know if you'd like me to take over, Sylvia. Ah, there you go.
Okay, let me make sure I'm sharing the right thing. So I'm hoping that you can see the slide deck.
No, you are on your homepage right now.
Okay. It's one last time. So first of all, I'd like to thank you all for joining us. We have a really incredible assembly of really terrific experts on telehealth. Again, I want to confirm, am I on the homepage or
Looks good. We see slide deck.
excellent. Okay, fantastic. I like being able to walk and talk at the same time. Slide deck or no?
Yes.
We are, but if you want to throw it in presenter mode,
Say that again.
did you want to throw it in presenter mode where we can't see your notes and everything?
Okay, we're gonna hand it over to Mariah.
Yeah, I got it. No problem.
Thank you.
I got it.
Sorry, guys, I was gonna try to, I was gonna try to drive this, but didn't work out. So
It's all good.
We're gonna do a quick adjustment. Okay, so we have a really amazing group here with us today. I'm gonna put some questions in the chat. And I think the question that we already received with regard to the regulatory payment issues, I'd like to get a sense of who is participating here with us today. And so feel free in the chat function to go ahead and share. If you're with the FQHC, if you're with a community provider, hospital, others, that would be really helpful as we think through some of the questions and the answers that we're going to provide. So I'm Sylvia Trujillo, Senior Director of Policy at OCHIN. Prior to OCHIN, I was at the American Medical Association for 14 years, where I focused on very disruptive areas of medicine, have worked with a number of the people on the panel to develop the remote patient monitoring codes that are being used now. And some of the folks are now also continuing on the remote therapeutic monitoring codes that we'll also be discussing. So we're going to have folks introduce themselves on the panel. I'm going to have Carol go next. Carol, you are on mute.
My controls were a little bit slow. So hi there, Carol Yarbrough here from San Francisco, University of California, San Francisco Health System. And that's a very short bio I gave. I've been involved with healthcare for about 18 years now. And I guess you could say I was involved in healthcare for additional 20 before that, working for defense litigation lawyers downtown. But yeah, I'm happy to be here, and thanks so much for allowing us to present on this informative panel for the attendees. Thanks.
Okay, Andy.
Hey, everybody. Thank you so much for having me. Andy Molnar, I'm the CEO of the Digital Therapeutics Alliance. I came into digital therapeutics and prescription digital therapeutics about 5 years ago now at Pear. Spent some time at Cognoa and realized that I really cared more about the plumbing of this industry and making things work for everybody, as opposed to just one product. So with that, spent a lot of time on policy, government affairs work, looking into RTM and RPM, and also reimbursement through other avenues. So looking forward to speaking with everyone.
Great, thank you, Andy. Okay, Robert Jarrin.
Hi, everybody. My name is Robert Jarrin, although everyone just refers to me as Jarrin. I am a strategic advisor in the area of coding, valuation, coverage, and payment of remote physiologic and remote therapeutic monitoring. I also serve as an advisor to the American Medical Association Digital Medicine Payment Advisory Group. I'm not here representing the DIMPAG or the AMA, but I do have some pretty keen insights on the creation of these codes. And just really happy to be here. Thanks to OCHIN and the California Telehealth Resource Center. And of course to you, Sylvia.
Thank you. Okay, Dr. Mishra.
Hello, everyone. It's a honor and great to meet you all. And I'm Vimal Mishra. Several roles. I'll talk about 3 roles specifically. I'm a physician. I'm internal medicine physician at UC Davis Health. I recently started here as a vice president for digital care. So all care around digital health I support for the UC Davis Health. Additionally, I also work with American Medical Association, and I'm not representing AMA here, but we're talking about this as a director for digital health, and do a lot of work around how can we make a technology an asset, not a burden for physicians. And in addition, I work with many other advisory groups, consulting on, talking about, and helping them how to get reimbursed, how to think about creating clinically validated models so that our patients can get best care.
Hi, yeah. I'm Jim Marcin. I'm also a physician, a pediatric critical care provider, also at UC Davis Health, along with Dr. Mishra. Been involved with telehealth for some time. And I guess my focus has been throughout my career and interest in evaluating the impact of telehealth technologies, kind of with a research perspective to evaluate which ones work, how they work best, what patient populations and such like that. So, and thank you very much for the opportunity to participate. Back to you, Sylvia.
Thank you very much. Okay, so today we are going to cover quite a bit of ground, but we are going to revisit some of the issues that were covered in the earlier presentation. And I think that's important because this is a very complex area, but there are some really foundational policy issues that we want to cover that could be both barriers to adoption that we need to advance policies to remedy, or present really opportunities for us to accelerate uptake and adoption. And part of today's discussion is to further elucidate those and advance those. And so we are going to cover some of the infrastructure issues that community health clinics and other providers face with regard to adoption, some of the opportunities to advance policies to support practice integration. We also are going to spend quite a bit of time around payment requirements and the regulatory implications of those requirements. And then certainly not to minimize, but sort of pooled throughout all of these discussions will be equity. But then I want to land on some really important equity issues, as clearly many of the participants here are providing support for communities in need and who may face disparate social risks. So with that, I'm going to have us transition to the next slide. I'm going to ask 2 of our panelists, Robert Jarrin as well as Dr. Mishra, to help us sort of focus on and elucidate between the 2 terms that were introduced earlier today around remote patient monitoring and remote therapeutic monitoring. And Jarrin, I'm going to start with you, and I'm going to ask you, if you would, to provide some context around how the most recent version of RPM codes were created and what brought us to the need to develop remote therapeutic monitoring so we can identify the differences between the 2. just
bet,
in terms
thanks.
of the definition.
Yes, you bet. Thank you, Sylvia. And I think you said it really well in the introduction. This is a very complex area, and it's very easy to become overly complicated by way of, the nomenclature or the taxonomy or the way that things are described. So, what is in a name is actually incredibly important, because what may be in a name for example, CPT or the American Medical Association, in the way that they describe a code, may be a little bit different for a payer such as CMS. And a great example is this slide. The question before us is, what is in a name? Remote patient monitoring. That is what really is popularly referred to, for this space. However, when the CPT editorial panel created these codes, they created codes for remote physiologic monitoring, which really dealt with physiologic parameters. The examples that they gave were things like weight, blood pressure, pulse oximetry, respiratory flow rate. And when you're talking about remote patient monitoring to CMS, they actually referred to another code, a code that had existed for 20 years and was actually bundled, although it had no coverage and payment assigned to it, which really was for the collection and interpretation of physiologic data. CMS really informally and now very formally refers to that code, CPT codes 99091, as remote patient monitoring. So what is in a name is actually really quite important, because that's how we know what we're referring to. And each one of these names has a different service that's assigned to it, with different types of intra-service work, as well as requirements. And then when you think of something like remote therapeutic monitoring, the idea behind remote therapeutic monitoring was to capture what could not be captured via remote patient monitoring or remote physiologic monitoring. Both of those really focus more on physiologic parameters, because the examples given for remote patient monitoring were somewhat similar by way of medical devices for that service. However, remote therapeutic monitoring really dealt with therapy adherence and therapy response in a particular, a particular part of use cases specific to the supply of that service. It's a little bit different for the treatment management service for that service. So I would end by saying that remote therapeutic monitoring, since it's not physiologic in nature and it's more based upon the adherence or the response to a therapy, that side of the code families really was intended to capture things that were not necessarily being captured by physiologic, nonetheless being produced by a medical device and producing medical device data off of which a provider can work. Dr. Mishra?
Now, Jarrin, you said it very well. And I think there is certainly, we can start thinking about, and if you have question, you can ask question around the application of remote patient monitoring and therapeutic monitoring. That might help clarify. This is a complex issue, as everybody referred here. So certainly when we are thinking about hypertension management or diabetes management, we are talking about physiological data, and the RPM code applies there. But when we are talking about musculoskeletal system or cognitive behavioral health system, which Mr. Williams just talked about, Mr. Englund just talked about, actually applies to digital therapeutic monitoring. And I think once we start applying these, and if there are case-based scenario, we can certainly come back and answer those questions. Back to you, Sylvia.
That's actually a really good point. And we're going to delve a lot more into these descriptors and the difference between the RPM and the RTM codes. And you're going to learn about what are called lumpers and splitters. Didn't think you were going to learn about this on the call, but it is a really helpful tool, and we'll get there. So I wanted to make sure that we started out, though, with a basic understanding of the terms that we're using, and then we're going to talk about some of the applications and how these RPMs and RTM codes are different. I'm going to see if Andy or Carol want to weigh in here at all. If not, we're going to move to our next slide.
Yeah, I think the only thing I would add is that at DTA, we focus a lot about enabling real world use. And this is such an important step in actually getting these products in the hands of patients, right? Is that the doctor can use it and get some sort of reimbursement for it. But I think you can also see how much work needs to be done when RTM, for example, is for respiratory musculoskeletal and CBT only. So, looking forward to continuing the conversation about what the future of these codes might look like.
Great.
Yeah, and you don't want me to talk yet because I'll just go right into the weeds.
Okay,
Right into
so
them.
yeah, we're gonna move now. So we're just doing definitional sort of clarity and then moving into the broader policy
Okay.
questions and then dovetailing into the specifics. So I want to start off really with talking to the physicians here and then opening it up to some of the other panelists, but both Dr. Marcin and Dr. Mishra, talking about your experience around connectivity. That certainly there's been a lot of funding in the past Congress as a result of COVID to address broadband. But in terms of what you're seeing happening, is broadband connectivity a factor in uptake? And does that remain a barrier to equitable uptake to remote any digital modalities, including RPMs? Dr. Mishra, you're on mute.
After 3 years, I would have learned, sorry. No, this is $1 million question. This is just an amazing question because I think we all talk about digital divide here, and we have seen this during our COVID period. So I recently moved from Virginia to California. So I wanted to kind of just create a parallel there. And in Virginia, our governor at that time actually had put together that it will be the whole state of Virginia would have broadband. It will be the fourth vital sign as and across the state. Because of the same reasons, during the COVID period, what we saw that many of the telehealth visits, we were actually calling our patients and we're getting the same kind of outcomes. We actually did create a code modifier to represent that this is also a valid way of providing services. Because of that digital divide, that everyone does not have that broadband connectivity. They do not have a way to have a video and audio as well connected together. We also saw during this COVID period that many of the students who do not have broadband were also left behind. So this is a part of a very important conversation around equity and how digital health connectivity should be a part of any kind of development in the future. And I really support this idea as, and of course, most of the patients who are in the rural setting do have poorer outcome. Also related to that, they do have issues with the connectivity, and RPM overall as a solution can really support these patients who are do not have access to the physicians. And we have seen this data after data, information and research after research is showing the difference between the outcomes for patients who have access and as well as access to the broadband, as well as access to the care. So I think it's an important topic, and it has to be part and parcel of everybody needs an electricity, everybody needs broadband expansion so that everybody is connected and support that way they can get care as well. So I'll stop there, Jim.
Thank you, Dr. Mishra. I very much agree. And I just want to add on to it that with respect to the connectivity access to the technology, telecommunications, that is absolutely an important piece, but I just want to say that it is just a piece. There are other factors that are more in our control as a deliverer of healthcare or provider of healthcare. I think that we need to focus on as well. You can't just say, oh, well, they don't have connectivity, so they can't use this. When you're developing user interfaces, the ease of the technology, the processes that need to be used to set it up, whether or not there's skepticism about these devices. There's a lot of other factors that are within our control. If you consider telecommunications and access to devices outside of our control, there's still a lot that we can do on our own end to make the delivery of these services equitable. I mean, we learned that here at UC Davis for sure. In deploying RPM and other video visit modalities. Yes, there's a technology barrier, but we still can do a lot on our end to help address the inequities. And then I'm so sorry, Sylvia, but on a broader picture about the practices and supporting RPM, all of this, it's just a bigger piece of the pie. Just like RPM is a slice of the pie, there's lots of parts that have to go along with it when you're trying to improve somebody's diabetes management or hypertension. It's not just popping a device in and saying that you've addressed that problem. Thank you.
Right. So actually, that's a great segue to our next question. So if we could move to the next slide, this really has to do with thinking about what are some of the challenges and opportunities for adoption into clinical practice. What are some of the impediments, and then the policy implications, right, of those impediments? Like, what are the steps that we can take as a policy matter in California? You know, the legislature's in session right now. The Governor Newsom is looking at right now a really tight budgetary situation. But as we think about reimagining healthcare delivery, and this is one tool that can be very impactful to increase access to underserved communities, where are those opportunities? And I'm going to sort of guide you both a little bit to the slides. They're at the back, but I'm going to have Dr. Mishra, if you could speak to, we're going to stay on this slide, but I'm going to have you speak to some of the research that's been done at the AMA around clinician appetite for RPM adoption and what that has looked like over time, the enthusiasm, and if there is an enthusiasm gap for that adoption and what you've learned from that. And then Dr. Marcin, you had a summary of sort of some of what we've known about adoption and what some of those factors are. And the folks will receive the slide decks with you with those details on them. But if you both can speak to those, and I'm going to start with Dr. Mishra.
Sylvia, thank you. I think this is very near to my work, what we do here. Certainly. So I'll speak from both the AMA perspective, the research we have done, and some of the implementation perspective, which we are doing at UC Davis, as well as my previous institution. So certainly this is one of the key factors when you start thinking about remote patient monitoring, and the outcome you will see is around how are we reorganizing and rethinking care? How are we thinking about, is this just an addition of an equipment in the clinical world that changes the outcome, or is this really integration of the digital information in a way where we are supporting our patient, what we call as digitally enabled care models, which is one of the most important and exciting evolution of what the virtual care modalities can do for us as we move forward. From the AMA perspective, in 2016 and before 2016, we were asking this question: what really matters for physicians from the perspective of physicians, and what are the key elements they are looking for to adopt a piece of technology? And we came up with the 4 buckets, which was, does it work? So what is the evidence that a tool as a technology, piece of technology work? What is the real world evidence around it? Has it been applied? The second question they ask about is, will they receive payment? If you are, that's a great piece of equipment, but if it's not reimbursable, how can they apply in their practice? And third is, are they going to be liable? Who is going to be taking the liability if we implement that kind of equipment or that kind of virtual tool in their world? And will it work, the technology, piece of technology? Because many of the technologies are done in a very environment which might not be the same. At UC Davis looks different in the patient population versus my previous institution with Virginia Commonwealth University. The patient population differs. The insurance population differs. So does it apply and does it work in their own environment? So we did create a survey across the nation, sampling about 1,300 physicians across the nation since 2016. And we have been publishing on those data points since 2016 around what really matters. For specifically talking about remote patient monitoring program, the recent study in 2022, what we published, showed the current state, about 34% of the physicians who responded to the survey said that they have currently incorporated remote patient monitoring programs in their practices, which was up from 22% in 2019 and 13% in 2016. So that is a good jump in terms of application and adoption of remote patient monitoring program. We also asked about enthusiasm and relevance and familiarity. That has also grown significantly, especially the enthusiasm. 50% of the physicians' practices said that they would actually implement an enthusiastic to implement remote patient monitoring program in their practices. And we also asked about what is the timeline? When do you think you will implement this remote patient monitoring program? And out of those patients, about more than 50% physicians said that within a year. So that's a great notion. That's a great result showing that there's a lot of interest from the physician and physician practices to adopt remote patient monitoring program. And their drivers of implementing and adapting remote patient monitoring program was around improved care. It was around improved healthcare outcomes was number one, improved diagnostic abilities. Many times these data points come and you're like, hey, when we see a patient in our clinical setting, we might not see our patients until 3 to 6 months about their blood pressure. And in that period of time, the blood pressure might be very different. Whereas with the remote patient monitoring program, we can see them every day if we are able to get that data, and we might change and titrate those medications much before they have an adverse outcome like stroke. So that is fantastic, and that's what they're excited about. The work efficiency, they think remote patient monitoring program, if they are integrated, they will improve the efficiency and increase patient adherence. If you really see the data around chronic disease management programs, 50% of the patients, the chronic disease patients from diabetes and hypertension, they do not have their diabetes or hypertension in control. Only 50% patients have that in control. It's not because the patients don't want to follow or the physicians don't want to work. There are only 3 levers we can pull. One is medication titration. Second is high density, high accuracy data. And third is the behavioral change. And the way our sick care system is set up right now, that we don't provide either 3 of them and cannot titrate them. And that's remote patient monitoring program can do that, so that we have that constant conversation with our patients, behavioral modifications, and hence improve the outcomes as well. And the patient safety was another reason. So the key requirements for physicians to adopt remote patient monitoring, that comes to the question, Sylvia, around the barriers you talked about. What are the barriers of adoption? The number one barrier, they said, it needs to be as effective as a traditional care. It cannot be less effective. Number 2, they talked about integration with the EMR. If I have to go to one more application to see my data, one more click, that's not going to work out. So that was number 2. And third, it was please reimburse for the care we provide, the time we provide. And the number 4th was around, we don't need more training. Can we create a digital solution so that I don't have to do one more module to understand how do I do things? And it should be covered by the malpractice insurance. So in a nutshell, this only about, and we asked several research questions. This was remote patient monitoring program was just one part of that question. And we have so much insight as to what physician practices are looking for, how they are thinking about, and what the future holds. And in discussion section, we will talk more about implementation practices and how the support staff sees that and how actually they can increase capacity of the clinics. And we have done this, and I have published on this, as how if you have the right supporting staff, it can actually increase the capacity of physician to see more sicker patients. So I'll stop there. Jim, you want to add?
Sure, I'll try and be brief, but first I'll start with 2 disclosures. One is that I'm a big advocate of telehealth, and I have no doubt that remote patient monitoring is going to be a part of our healthcare delivery system and in the future for sure. But the second disclosure is for those of you that have seen the Disney movie Inside Out, the characters inside Riley's brain, I'm a little bit like Fear. Be cautious with all of this, because while it is a part of our future, we just have to be very thoughtful about our implementation. That slide, I think Dr. England is still on the call, but that he flashed up a study from 2018 that showed a meta-analysis to demonstrate that there are research studies out there. What he didn't mention was that that study was a negative trial. It looked at 27 studies evaluating activity trackers, and the meta-analysis did not show any difference of the use of activity trackers on waist circumference, weight, BMI, systolic blood pressure, diastolic blood pressure. So the implementation of those studies weren't yet working. We're getting better at remote patient monitoring. And at the end of the slide deck, I quote a BMJ study that was published that looked at lots of RPM studies like COPD, hypertension, diabetes, things like that. And they found about half of the time the RPM projects and studies worked, but that means half of the time they didn't work. And so we just have to be thoughtful. And that's like in terms of reducing admissions, half of the time it worked, reducing length of stay, half of the time it worked, reducing ER visits, half of the time it worked. So we have to learn better on which populations we are targeting, which are the most at risk, being able to accurately detect a decline in health, being able to provide responsive and timely care from these remote patient monitoring modalities, having it personalized for each individual patient, enhancing self-management, which we know is an important factor in improving outcomes, and just ensuring that we have collaborative and coordinated care in these modalities. So again, recap, all for this, but we really have to be thoughtful. I don't know that it's prime time necessarily to jump in a lot of these modalities without being thoughtful. Thank you.
Yeah.
Back to you, Sylvia.
Yeah, so I think this underscores a long discussion, and we're going to segue now to the next slide with some really significant, I think this might be a duplicate. Are we moving to the next slide? Okay, great. I want to underscore, and Jarrin, this is where I'm going to ask you to sort of weigh in a little bit, that the creation of these codes really was, as Dr. England mentioned earlier, a function of a tremendous amount of work done by hospitals. So the research around RPMs initially was focusing on outcomes as a result of efforts by hospitals to reduce penalties for readmissions. And so they very quickly invested in RPM programs that then improved their patient outcomes so they weren't readmitted to the hospital. So I think really, Dr. Marcin, what you're talking about is, and Dr. Mishra mentioned this as well, is that deployment in one place doesn't mean success in another place, and deployment for a certain service or line of services is not going to be necessarily equally apt across the board. And so that's actually really relevant to how the codes are created, because it turns out the RPM codes are what are called lumpers. It covers a broad ranges of services that could fall under the auspices for a lot of different conditions, whereas the RTM codes are what we call splitters. They're specific, they're not a big lump. They're cut into very specific tranches of services, and they both have policy implications as a result for who can use them and when they can use them, and how the evidence will develop and how those services will be covered. But I wanted to make sure, as a threshold matter, that everyone on this webinar understood that we are going to be talking about 3 different things in this discussion. And this is sort of where the confusion often occurs. The first is that a service has to be described, and the service is a service technology combination. And those services are described typically for the services we're providing through the current procedural terminology called CPT. And as a result, the American Medical Association and the CPT editorial panel have a tremendous amount of influence over when a service even has the ability to get paid, because you have to have a code, a billing code, in order to get paid for the service. And it turns out it's really important how that service is described, because it impacts how you can implement it in practice. And even when you have a code with a description, different payers may pay it differently. And then they may also pay it in different amounts, right? It may be fee for service. It may be lumped into a prospective payment system. So it's very important, because many of our audiences are associated with providers. Federally qualified health centers, a very large percentage of the patients they're serving are covered by Medicaid. It is really important, if we go to the next slide, that as we have this discussion, we make really clear about whether or not we're talking about a Medicare population, a Medi-Cal population. And I should have done this for Medicare as well, that Medi-Cal, FQHC, rural health clinic policies, and then commercial plans. Because it turns out both Medicare and Medi-Cal may have a general policy as it relates to RPM and a different policy as specifically applied to FQHCs. And most of the conversations that occur promote a form of structural inequality, because they fail to actually account for the payment policies that are applied to FQHCs. So with that in mind, I'm going to ask folks that as we have the conversation, the panelists, that you make clear if you are talking about Medicare and you are not including Medicare policy for FQHCs, that is clear. Similarly for Medi-Cal, because again, I think one of the barriers faced by FQHCs and rural health clinics is they hear that RPM or RTMs are covered, only to find out when they go to find whether it's covered for them, it's not. Okay, so with that, let's move to the next slide, if we could. And I'm going to do a real quick time check. We have about 40 minutes, but we'd like to leave about 10 minutes for Q&A. So we've, I think, already gone over the codes we're going to be talking about are the current procedural terminology codes from the AMA. I will hasten to add that CMS also develops their own codes, but they are not implicated here. So I'm going to avoid talking about other code sets that have been proposed, but for everyone here who will become subject matter experts and ambassadors for their organization, it is important to know that in the future, there could be codes other than CPT codes that are proposed by Medicare for CMS, or by CMS for Medicare. And that will be another webinar a year from now, potentially. So with that, we are going to have several folks. Carol, start to get yourself ready there. And Andy and Jarrin talk a bit about the real nitty-gritty differences between RPMs and RTMs, because it's not just in how they're described, but it also is differences with regard to who can provide the service and whether or not others can provide under the supervision of a clinician who can bill. So we're going to go to the next slide. And these again have policy implications for access. So I'm going to start off with Jarrin. Both you and Dr. Mishra alluded to this, but I'd like you to make really clear the differences between the range of conditions that you can use an RPM with versus an RTM, because I want everybody to leave today understanding the fundamental difference between these sets of codes.
Sure. So when we're talking about the remote physiologic monitoring codes, CPT codes 99453, 454, 457, and 458, the codes are really broad, like you said, lumpers, and I'm glad that you brought up that term. Lumper being that it's a code that can capture general physiologic, a general physiologic service. I'll say it that way. the range of conditions wasn't ever really prescribed by CPT, nor was it ever really formally described. However, the code, a family itself, was placed under the evaluation and management section, which then has certain stipulations that are attached to it via regulation, really, CMS being the payer. Under E&M, there are only certain types of providers that can actually bill or report that service. And further, within the E&M family, the remote physiologic monitoring codes were placed under care management services by CMS, which meant that CMS allowed those codes to be able to be furnished incident to, which is really allowing the providers who can bill these codes to do so by generally supervising auxiliary personnel or clinical staff. And really importantly, who are those providers that can bill E&M services? There's really only 5 types. One is a physician, the top of the food chain, a medical doctor. The second would be a nurse practitioner. The third would be a physician's assistant. The fourth, a certified nurse specialist. And the last being a certified nurse midwife. So those are really the ones that can bill E&M services. However, they are allowed to institute the services of their clinical staff or auxiliary personnel to do some aspects of the work. And I say some aspects because it's very important that whoever that personnel is not exceeding what they can actually do. They have to fit within their scope of practice, whatever education they have, whatever certifications they may have, et cetera, et cetera. So, it's very important to understand who exactly would be helping. When it comes to remote therapeutic monitoring codes, those codes were placed under general medicine services, which means that a broader array of providers can actually bill and report those codes. However, that also comes with the limitation that incident to services typically are not allowed. It wasn't until this year that under the 2023 physician fee schedule, CMS made a policy clarification, thereby stating that they would allow the remote therapeutic monitoring codes to be able to be billed also under incident to general supervision services for those providers that typically can bill E&M. So that would be the docs, the NPs, the PAs, et cetera, that I was describing. However, under general medicine, you have other non-physician practitioners that can bill these codes, which include service providers such as physical therapists, occupational therapists, in some instances, speech language pathologists, et cetera. They, unfortunately, it's unclear whether or not they can actually do services incident to. There is no such policy for non-physician practitioners. However, that OTs and PTs, for example, often use OTAs or PTAs, those are occupational therapist assistant or physical therapist assistant, to do some of the work. So that is a policy clarification that, I think a lot of stakeholders are looking for in the 2024 fee schedule in advance of that, rule, which, the proposed rule should be coming out sometime in July. So that would be my side. I don't want to take up the time for everybody because we're really beginning to run out of time. So I'll go to the next panelist.
Yeah, before you do it, I also want to interject. Jarrin was talking about Medicare. So
yes, thank you. I will only be talking about Medicare.
Right. It is super,
yes,
super important, right, to clarify
yes.
that everything he just elucidated in terms of every item below the range of conditions about who are the practitioners and what type of supervision. I do want to say, though, the codes are written in such a way that it forces the hands of payers to adopt those policies. So it turns out that the policy implications of how we want to expand access and greater flexibility to account for the realities of staffing, for example, in an FQHC where we may have fewer MDs and we potentially could have fewer individuals that could bill an E&M code, that it would be important to have expanded number of practitioners that within their scope within their scope could supervise others, would have code descriptors that would allow them and payers to cover those services. So it's likely that most Medicaid programs oftentimes will follow suit, but the particulars for an F2HC can differ. So with that, I'm going to open the door to Carol to provide insights about some additional differences that may apply, particularly in the Medi-Cal program, if you feel it's appropriate, Carol, to ask that question.
Yeah, I just want to kind of elucidate and maybe expand on a few things that Jarrin was talking about. Certainly in terms of where you can perform incident to services. A lot of folks on this webinar are probably from facility-based healthcare institutions or facility-based health systems. And anything that he said about incident 2 does not apply to facilities. So only the eligible E&M providers can bill the codes that have to do with evaluation and management, in particular with regard to RPM. The other 2 codes, and Sylvia kindly provided a couple of slides in there towards the end as sort of an appendix that show that for a facility, you're going to build the first several codes out, both for RPM and RTM via OPPS. So it's a different reimbursement. Services are ordered at a facility. Then the facility performs those tasks for you or your labs or whatever. So the RPM, the first 2 codes get performed for you per order. You can get referred to RPM, say for like a vendor, all of a sudden. So say you're in a facility and you've got a contracted agreement with a vendor and you're like, okay, I'm going to refer you to RPM. And so through whatever professional services agreement you're associated that you've enacted, that referral and consent can be done either at the facility or at the vendor level. So with reporting going back to, the doctor who wants that information. With RTM, it's great that it's in the medicine section of the book. They are, what's crazy is they call them sometimes, it's supposed to be remote therapeutic monitoring. There's sometimes therapy codes. That's why doctors can bill for them, doctors, NPs, PAs, midwives, and not just allied health providers. So, just think about on webinars, I used to say, just think about where you sit in your clinic. Like, what kind of clinic are you in? Are you a non-facility, a facility? And what kind of provider you are? And that kind of orients you to where you can provide virtual care. Okay, I'm done.
So this is super helpful. And I'm going to get to the really important question Joaquin Luke submitted. And Andy, I think this is where you're going to shine. So it's really about, unfortunately, it's not applicable to California, but I think this is really where the policy issues start to, the rubber hits the road. Andy, if I could have you share with us some of the work that's being done to secure coverage in a Medicaid program. And in particular, I'm thinking about Massachusetts. And maybe you could share a little bit about the work that you all and your members are doing to try to expand access in Medicaid to these types of services.
Yeah, absolutely. And I think it's what I do is also like outside of RTM. So a lot of the reimbursement pieces that we work on is with Medicaid and Medicare through fee-for-service potentially. And so if we look at digital health or digital therapeutics type products, the products themselves can cost one amount, right, as if you're like prescribed a drug. Whereas the piece where the providers are monitoring the patient is a separate reimbursement piece of the whole overall care setting. right? And so, like, for example, Pear Therapeutic substance use disorder product, there was no remote therapeutic monitoring codes when that was launched, but they were still dispensing the product to help patients. It's just that any doctor that was monitoring that patient could not get paid for that time. So it was a piece of the puzzle or a piece of healthcare delivery that was technically broken and made it harder to have patients actually use the product because the providers weren't really sure how to integrate it entirely. And so with that being said, Medicare kind of leads everything, from a coding perspective. And CMS, when Medicare was founded, I should say in 1965, nobody thought that in 2023 that we would all have computers in our pocket, right? So they thought everything would happen within the four walls of the doctor's office or the hospital setting. And that was, great for back then, but it took until the early 2000s to even have a drug benefit. And so with that, it's kind of even a broader innovation issue, is that software as a medical device is not paid for, right? In general, which is and that's like a very important issue that we have to face, for whether it's digital therapeutic product or otherwise, outside of some time that the doctor spends on it, the products themselves have no place within Medicare, which means that they don't have proper coding. And so when you look at these products that patients are using that doctors need to be reimbursed for working on, we were trying to get Medicare to lead that way. And so what we did was introduce the bill last year called the Access to Prescription Digital Therapeutics Act. And it defined a prescription digital therapeutic, but it also made CMS define a benefit category. Now that bill did not pass. It will be reintroduced again in about a week. So you guys can look for that. But that benefit category piece has been huge. It's been an issue even for things like colonoscopies. They had to create a whole new benefit category as well. It's very, very difficult for Medicare to say they'll do that, even if it's something obvious, right, that really should be done for the future of healthcare. I think like Jim was talking about, like, this will happen. It has to happen correctly. It took a pandemic for telehealth to happen, even though we knew that was going to be good, I think, right? But when telehealth first came into play, there were a lot of issues with it. So that being said, at the same point, we were looking at Medicaid, because Medicaid can technically cover digital therapeutics products. They have options in a lot of different ways. Things like in lieu of services. They can say, oh, we're going to cover this because it's the same price as something else, even though it's not covered from a Medicare perspective. It's not coded properly as we would anticipate it. And Medicaid also has the ability to cover things outside of your traditional healthcare needs, things like pillows and, for children, right? If they have issues with like musculoskeletal issues, for example, they can cover pillows and things like that. So it's a little bit more flexible. With that, Massachusetts started a pilot last year with Pear Therapeutics within their substance use disorder space. Massachusetts is always a leading state when it comes to Medicaid. And with that, now we've seen other states like Florida and Oklahoma also move forward with covering digital health products differently. Under fee for service. So durable medical equipment, but paid for on the pharmaceutical benefit. And so with that, even though we had a bill that we introduced last year for Medicaid, which was a federal bill where CMS would tell all of their state Medicaid medical directors that they could pay for these products, the bill didn't pass, but we don't need it. It was like a legislation to say that you could do what you're already allowed to do. The reasons that came about, I will leave off this call because we only have 20 minutes left. But with that, we're actually now seeing Medicaid move faster than Medicare. And we're seeing commercial pilots start to move into actual coverage. So with that, like, we're still in the very early phases of how people will apply this, but it's like, it's happening regardless, And so to Jim's point, how do we make sure we do it right? Because it is going to happen.
So Andy, looking across, your alliance is national in scope. looking into your crystal ball and thinking about California and the Medi-Cal program and sort of where is the momentum to drive policy to expand access, particularly given FQHCs in particular face barriers right now that are coverage and payment barriers to widespread adoption. Where do you see us going here in California?
So actually, a lot of the larger payers in California have commercial payers have been on top of this for a while. I mean, Kaiser has their own digital backbone, and I forget what the Blue Cross is in California, but they've piloted many different products. But also last year there was legislation for it came through because of the opioid epidemic, where they actually included VR for pain as something that could be covered. So, or companies like Applied VR, which is for chronic lower back pain, has like a future based on that legislation as being something that's covered. And so I would say California is probably not too far behind the rest of like the innovative states that we're looking at now, especially with Florida. I mean, Florida is like a really big Medicaid state to move this early in the game.
And so I'm going to put you on the spot. So your alliance represents many of these innovative companies. And is there an appetite to move forward to expand this access for Medi-Cal and FQHCs, given so much, particularly you mentioned Therapeutics is really focused on the opioid epidemic and really extending and expanding capacity within community health clinics and FQHCs is a mission critical need right now. To what extent are these companies or organizations working on legislative solutions to expand that access to underserved communities?
That's a great question. I would say I haven't heard much about that at this point, because we're almost focused on just the basic, like nobody can pay for this, or nobody will pay for it, I guess. And so with that, and even when you look at RTM and RPM and who's used those codes over the past 3 years, it's not like you're looking at a huge number, right? And RTM is very low, but that's, I mean, obviously it just came out. So I would say it's on everybody's mind. It's really like the promise of digital health is that it would be health equity and it would serve the underprivileged communities. I have not, though, seen any specific legislation for that, other than in the context of the legislation that we move forward, we bring that up consistently, especially because Medicare and Medicaid is who's covering those individuals.
Right, and Carol, one of our panelists, just correctly called out, again, I need to make sure I make the distinction between what Medi-Cal covers versus what Medi-Cal covers for FQHCs and rural health clinics.
Not to like over confuse it, but the Medi-Cal covers RPM, but Medi-Cal doesn't cover some of the products and the cost of those products that ultimately deliver RPM.
Well, that's supposed to be covered in the 99454 reimbursement, because that's the monitoring and equipment code. Right. So if you're going to look for reimbursement for a blood pressure cuff, that's supposed to be covered by 99454.
Yeah, you're right.
And it doesn't really cover it.
Yeah, so I think the issue though might be about the reimbursement amount. So that's the last sort of threshold issue is for developers, whether it's sufficient to cover the actual costs of what they're producing. So bottom line is, I think we're getting very close to our time. We want to make sure to open up the floor for other questions, but I do want to move to that.
Can I break in for just
Absolutely.
one little sec?
Yeah, absolutely. Yeah.
This issue of the valuation is actually a very important issue, which I'm not sure anybody out there really understands other than the coding, valuation, and coverage nerds. And I just want to make sure that people realize they're not necessarily paying for a blood pressure cuff monitor or a weight scale, even though they reference those in the examples of the descriptor. What ended up getting valued by the RUC, the RUC is the Relative Value Update Scale Committee, something or other. It's another component of the AMA. And what happens after a CPT code gets created is this wonderful report of codes goes over to the RUC. The RUC then sends out a questionnaire, really asking for economic, statistical invoices and other data from medical specialty societies that all belong to the AMA hierarchy, to then opine and give this information so that they can come up with a proper valuation for a procedure, a service, a supply of equipment, for example. When these codes were created, there was only one invoice that was submitted by any specialty society. And that invoice was by the American College of Cardiology for a remote physiologic cardiophysiologic monitor. And that invoice clocked in at about $1,000. And that's in the RUC report. You can go all the way back to 2018, I believe, which is when they issued that report. So when the RUC valued that code 99454, it was premised on one invoice from ACC. And when that report went back to CMS, CMS used that valuation to come up with the payment for 99454. In CMS's eyes, they're paying for a $1,000 cardiophysiologic monitor. Why is that important? Because this falls into the practice expense methodology that is something that CMS follows. For practice expense, for medical equipment, CMS has a threshold amount of $500. I don't know of many blood pressure cuff monitors that clock in over $500, at least ones that are used in the home. And if it were under $500, they technically can't pay for that. So there's a huge problem with the valuation of supply code 99454. Now compound that with the future codes that came out, the splitters, which are the supply codes for RTM. That includes respiratory, musculoskeletal, and of course CBT. CBT does not have any pricing assigned to it, was sent to the contractors. But the first two, 98976 and 98977, which are for respiratory and musculoskeletal, those were crosswalked, that's CMS fancy parlance for. They were connected to the existing 99454 code and given the same valuation, which means that, in my opinion, the supply codes are all living on a house of cards because they are all premised on a $1,000 cardiophysiologic monitor, which is exactly what CMS thinks that they're paying for, and obviously what is not being used for remote physiologic monitoring or remote therapeutic monitoring. So I just want to let people simmer with that for a couple of seconds, because that is a very important component of why we have trouble in this area. And I'm not trying to say that that's trouble and, boy, this is all messed up and it's bad. It is bad. It needs to be fixed, but not at the consequence of getting rid of these services. And I think that's a really important thing to say, because nothing is perfect. And when these codes were created, they were created the way that they were created because that was the context at the time. But now as we have grown, we really have to revisit all of this and hopefully get it right in the second time.
So I'm going to fast forward us because we've now gone into a really technical set of areas, and I want to sort of bring us back up to some broader policy issues. So I'm going to have us move to the next two slides, I think. We're going to go one more. Okay. And then we'll double back to audience questions. So we previewed this conversation for our participants to sort of lift up some of the challenges and policy opportunities that we need to advance. I think it's fair to say that we need much greater attention on sustainable coverage and payment for community health clinics and FQHCs in particular. We also need much more education about the deployment of these tools and these services for underserved communities and those that are billing as FQHCs. And so that is one major impediment. The one thing that we glossed over was Jarrin sort of both you and Carol might be able to speak to this, and it has to do with direct billing and incident to billing, the RPM codes. The folks that can build 2 of the early codes, the setting up, the education, and even the provision of the device. My understanding is that could be staff that's under supervision. My question to you is, would that potentially also include community health workers?
Carol, you want to start off, and I can pinch it for you?
Okay, so the community health workers could potentially do the education and training. I think that's what the question was asking. I was reading through the comments. I admit it. I'm bluffing.
Okay, I'll pinch it. So, so Sylvia, the way that I'm going to answer this, right? I can't answer, community health workers, because I tend to think of this under the lens of CMS, right? We're talking about, Medicare as opposed to Medicaid, et cetera, et cetera. But under Medicare, CMS came out in 2021 and stated that in order to be able to, fulfill those codes 99453 and 99454, it could be done using leased or contracted employees. Why that's important is because both of those codes are PE only codes. They do not have any work RVU assigned to them, which means that providers, actually the provider time and intensity, the work that they do is not accounted for in those codes at all. It's really the practice expense, and under practice expense, what they're paying for is medical equipment, as I mentioned, medical supplies, and then something called clinical staff time. So clinical staff time is accounted for in those codes, but they came out and said that also includes leased or contracted employees. Would a community health worker be considered that? I would argue probably yes, but I can't really speak to something outside of what CMS said.
Okay.
Right, so the CHWs have been recognized as people that can get NPIs and submit billing for their work. And in California, as long as it's in their scope of practice, where they're recognized, where they're with their agreement, under their employment agreement with their facility or with their community health center. Yeah.
So, and I want to draw that distinction because it's also my sense that community health workers under all of the payment programs, largely because of the way the codes are constructed, that would be allowable. It's not the case for RTMs. That is much more ambiguous because of the way the RTMs are constructed. Would you agree?
I will say it this way, CMS, again, on CMS lines, I'm the Medicare guy, right? So CMS made a number of very important clarifications for RPM codes in the 2021 fee schedule. Unfortunately, they never came back when the RTM codes were delivered the following year. They never came around and said, by the way, everything that applies to RPM now applies to RTM. To me, that's still a question in controversy. So I would agree with you because of the ambiguity, the lawyer in me would say, don't assume, because it makes, blank and blank. So yeah, I would agree with you, but that I would assume that what was provided, the requirements that were provided for RPM should most probably apply to RTM as well, but that was never clarified.
Okay, great. So we're going to wrap it up, and we're going to bring it back to some of the highlights. I want to thank our panelists. You provided, I think, a lot of food for thought. Hopefully we haven't further confused or conflated or confounded our participants. And I think we're going to have some folks that are actually applying RPMs in their practice under the conditions that we've talked about as FQHCs. So I encourage our panelists to stick around to learn from the folks that are in the field and marry that, because many of the folks that are on our panels actually are sitting at national and state level tables driving policy changes. So I think they'll learn a lot, as will I. And I just want to underscore that we know right now that there are going to be some challenges as the public health emergency flexibilities at the federal level start to sunset. These are flexibilities related to program integrity. We also have some concerns around co-payment obligations, patient consent requirements, We talked about connectivity, and then of course, we are looking for new opportunities to grow the care team, to expand into both staff who are community health workers, but other staff that handle technical or have technical training that can also be leveraged for purposes of standing up RPM and RTM programs and working with patients to do that in new ways. But it is abundantly clear, I think, to everyone that coding clarity is needed. It's also very clear that it's going to continue to evolve. So with that, I'd like to thank you all, and we really appreciated this opportunity for this dialogue. And it should get very interesting as we move into the individual providers and clinics that are implementing RPMs in California. I'm going to hand it back to our hosts.
Awesome. Thank you so much, Sylvia. That was a great panel, everyone. If anyone has any questions, now is the time to ask them for our panelists kind of directly about policy. As I kind of mentioned in the chat to Anne, we are going to have some health centers with active RPM programs talking about their experiences with, reimbursement, just the programs in general. So they might be able to provide some maybe less confusing insight, just because policy just gets crazy, as you guys discussed. So yeah, if there are any questions, go ahead and type them, preferably in the Q&A, just because things get lost in the chat. But while we wait, we're going to launch another poll.